Hey folks, Professor Finn here, and today we're going to be looking at Embalming History, Theory, and Practice 6th edition by Sharon Gee-Mascarello, Chapter 22, Vascular Considerations. Let's go ahead and get the screen shared and dive right in. So, vascular considerations. Arterial embalming utilizes the entire blood vascular system to distribute the embalming solution throughout the body. Arteries carry the embalming solution to the capillaries. At the capillary level, some of the solution will move into the interstitial spaces and make contact with cells and cellular proteins. The solution remaining in the vascular system moves into the veins and forces the blood present to be eliminated in the form of drainage. Damage to the vessels within the system hinders the embalming process. Natural degenerative changes in the circulatory system are common with aging. Pathological and traumatic conditions can also cause damage. When damage occurs to any of the vessel layers, the opening or lumen can narrow or become fully obstructed. Layers. Ogres have layers. So do your arteries and veins. Both arteries and veins have 3 layers. First up is the tunica intima, or the intima, the inner lining of endothelial cells which continue to form the walls of the capillaries and then the inner walls of the veins and arteries. This endothelial layer of cells lines the entire blood vascular system. The tunica media, the middle layer composed of muscle cells and elastic tissue. And finally, the tunica externa, also known as the adventitia, the outer layer composed mostly of connective tissue. Heart and vascular disease, along with prescribed drug therapies, influence the integrity of the vascular system. Any type of intravascular condition that changes the structure of the blood vessel walls or affects its lining is of concern. Arterial sclerosis and arterial coagula are quite common and frequently encountered by the embalmer. Arterial sclerosis. Arterial sclerosis is a pathological condition causing the arterial walls to thicken, harden, and lose elasticity. Diet, exercise, heredity, and stress are precipitating factors. This condition affects all age categories. Arterial sclerosis is more commonly noted in the femoral arteries than the common carotid arteries. The severity of the condition determines whether the artery is viable for injection. In type 1 arterial sclerosis, the intimal wall of the artery is thickened. The lumen is well defined. Use of a standard size arterial tube and unrestricted injection is expected. So the artery is getting a little bit harder, but there's not really any occlusion, and you just have to do business as normal with some maybe minor considerations that the walls are hard. Type 2 vessel walls are thickened and or hardened. The lumen size is reduced and off-center. A smaller gauge arterial tube is recommended for injection. So type 2, we have the first real blocking of the artery. And finally, type 3, the lumen is completely occluded and the artery cannot be used for injection. Collateral circulation can circumvent a blockage and continue to circulate blood beyond the area of occlusion. As the severity of the condition increases, a process called canalization creates tiny pathways or canals within the vessel to allow the passage of blood. In comparison to other arteries, the common carotid artery less frequently exhibits arterial sclerosis and is a good choice when vascular problems are anticipated. Begin injection at low pressure and slow rate of flow. Increase as solution distribution is evidenced. When distribution is mediocre, the strength of the arterial solution can be increased. A stronger solution supports sufficient preservation when a large volume cannot be distributed. Multi-site injection allows for higher pressures and pulsation to establish local distribution. Once circulation is established, the pressure and the rate of flow can be reduced. Co-injection chemicals aid in both fluid distribution and diffusion. Dye is added to indicate which tissue have and have not received solution. Firm massage helps to move the solution to the affected area, and lowering the hands or feet below the sides of the table increases distribution by gravity. When the femoral vessel is sclerosed, avoid forcing the arterial tube into the artery. Damage to the intimal layer can cause the lining to shed and block the lumen. Choose an area of the artery to incise that is not thickened by fatty deposits or atheroma. The vessel wall is weakened in the area and can easily rupture. Make the incision in an unaffected portion of the artery. Sclerotic arteries are less flexible and may not tolerate being stretched and raised from the incision. Secure arterial tubes in place with an arterial hemostat or thick cotton ligature. Thin linen ligatures may tear the vessel. Aortic aneurysm. Ruptured abdominal aortic aneurysm can significantly impair arterial solution distribution. Restricted cervical injection is a recommended best practice, and a single-site injection is improbable. Extreme facial edema and sclerotic femoral arteries can be anticipated. Use a strong arterial solution with additional dye to trace distribution. Inject slowly and continue to inject if drainage is established. If no drainage appears and the abdomen immediately swells, stop the injection. This indicates a loss of embalming solution from the ruptured aorta into the thoracic and abdominal cavities. Begin multi-point injection to sectionally embalm each of the body areas. The trunk walls may require supplemental injection using a hypodermic or infant trocar. Valvular heart disease. Disease or malformation may prevent the aorta from being the center of arterial solution, according to Murray M. Shore in his article, Damage to the Aorta May Bring Embalming Problems. Because of the position of the aortic semilunar valve, embalmers generally consider the aorta as the center of arterial fluid circulation. In most cases, this seems to be true. In the absence of damage to the circulatory system or the heart, it is only after the aorta is filled with fluid that its branches can be expected to receive fluid under any appreciable pressure. It is when the heart valves are impaired concurrently that embalming problems are created. The functioning valves of the heart are the left atrioventricular or mitral, which allows blood to pass from the left atrium to the left ventricle, the right atrioventricular or tricuspid, which opens from the right atrium into the right ventricle, the pulmonary semilunar, a tricuspid valve which opens to allow blood flow from the right ventricle into the lungs via the pulmonary artery, and the aortic semilunar, a tricuspid valve that opens into the aorta from the left ventricle. During life, heart valves can be affected by congenital malformation, bacterial damage, and the same degenerative diseases that affect arteries. When the mitral and the aortic semilunar valves are damaged, embalming solution injected under pressure moves from the aorta into the left ventricle and then into the left atrium. The left atrium receives the pulmonary veins from the lungs. The pulmonary veins do not have valves, so the embalming solution in the atrium, under pressure, passes back into the capillaries of the lung. The result is the purge of embalming solution from the lungs. The pulmonary capillaries also receive fluid from the bronchial arteries from the descending thoracic aorta. When the two fluid masses meet, the first from the bronchial arteries and the second from the pulmonary veins, the collective volume and pressure creates lung purge. The contents of the hollow portion of the lungs are virtually squeezed through the trachea. So what are we looking at here? What we're looking at is we start injecting, fluid goes through the heart because of all the valvular failure, and then starts to go into the small capillaries and arteries of the lungs, right? And on the other side, we are injecting through the aorta, and it's going down the descending thoracic aorta, et cetera, and there are branches from that as they wind through, also go into the lungs and meet on the other side. So we have pressure coming one way, pressure coming from the other, and this causes the lung to squeeze. And as it squeezes, it forces the contents out of the trachea, out through the mouth, and that's where we get the lung purge from. Congestive heart failure. When congestive heart failure is the primary cause of death, these complications are commonly noted. Blood is congested in the right side of the heart. The neck veins are engorged with blood. Facial tissues are discolored due to blood congestion. Lips, ears, and fingertips appear cyanotic or blue-purplish discoloration. Generalized pitting edema, ascites, and edema of the legs and feet may be present. Blood may be more viscous due to increase in red blood cells, which is known as polycythemia, and salt is retained in the body fluids. Selection of the right common carotid and right internal jugular vein or restricted cervical injection is recommended for congestive heart failure. And If you need to go that route, multi-point injection should also be practiced. The first gallon of arterial solution is prepared as a mild solution to clear blood congestion and discolorations. When edema is present, subsequent solutions are mixed stronger to meet the preservative demands of the tissue. Severe ascites and intestinal gases create pressure upon the inferior vena cava that can prevent adequate drainage from the lower portions of the body. Edematous fluids can be drained using a trocar or drain tube. Incise the skin at the point of entry with a scalpel and insert the trocar into the ventral portion of the abdominal cavity to prevent puncturing any of the major trunk vessels. Lower the arms over the table at the onset of arterial injection to promote capillary expansion, and this will help clear discolorations from the hands and fingers. Massage facial tissues to clear discolorations. Drain from both the right and left internal jugular veins when extensive discoloration of the face is present. Use continuous drainage until congestion has cleared. Pressure and rates of flow may be increased as the embalming progresses. The pressure and rate of flow should be sufficient to move arterial solution through the entire body. The liver may be enlarged and its functions decreased. This should improve drainage as the level of clotting factor in the blood will be low. Anticipate lung purge, and coat the facial tissues with massage cream and allow purge to continue during the embalming process. Perform thorough cavity treatment and pack the nasal cavity with cotton after embalming. In the presence of anasarca or generalized edema, good distribution and drainage is anticipated. However, ascites deletes cavity fluid. Reaspiration and reinjection of the cavities may be indicated. Distension in the neck tissues can be removed during cavity aspiration. Direct the tip of the trocar into the neck and channel the tissues. Vasodilation and vasoconstriction. The dye used to trace the distribution of arterial solution can indicate that one side of the body has received a large amount of solution and the other side a small amount. This difference is often evident down the midline of the body. This unequal distribution of arterial solution is evident in death from cerebrovascular accident or stroke. Vasoconstriction occurs on one side of the body, while vasodilation, in an effort to supply more oxygen to the tissues, occurs on the opposite side of the body. Multi-site injection may be necessary with injection of a sufficient quantity of solution to remedy the discoloration. Blood vessel clots. Internal changes within an artery or a vein cause the lumen to narrow or collapse, creating resistance within the vessel. This is called intravascular resistance, and it restricts flow within the vessel. Blockages caused by clot formation are commonly encountered during embalming. At death, some blood remains in the arteries, especially in the large aorta. During the post-mortem period, this blood can congeal. Injection of the arterial solution may loosen and push coagula into the smaller arteries. When the common carotid is used as the primary injection site, arterial coagula are moved into the iliac and femoral arteries. The femoral arteries can be injected at higher pressures to clear coagula and embalm the legs. Supplemental hypodermic and surface embalming enhance the areas that do not receive sufficient arterial solution. When the femoral artery is used as the primary injection point, coagula can be moved into the common carotid arteries and prevent arterial solution from reaching the facial tissues. Arterial coagula can also block the left subclavian artery. Raise and inject the axillary or brachial artery to embalm the lower arm and hand. Venous coagula. Small venous blood clots are readily cleared through blood drainage from the right internal jugular vein. Heavier clots lodged in the right atrium can be reached with angular spring forceps for manual removal. Coagulum that cannot be removed can lead to tissue distension and discoloration. Massaging from distal points toward the heart promotes thorough blood drainage. Intermittent drainage also helps to increase venous pressure and loosen coagula from the veins. Multi-site injection and drainage may also be warranted. When this condition is encountered in a localized area, use a stronger arterial solution to ensure that a minimum amount of arterial fluid delivers the maximum preservative. Diabetes. Arteriosclerosis, cardiovascular disease, hyperlipidemia, obesity, and poor peripheral circulation are common comorbidities with diabetes. Proper fluid selection and thorough distribution are primary embalming concerns. The presence of increased bacterial and mycotic infections requires strong arterial solutions. To assist in establishing distribution and clearing of blood discolorations, the first gallon of arterial solution can be milder than subsequent injections. Use of a co-injection fluid assists in clearing discolorations. Restricted cervical injection is suggested with a moderate to high pressure to distribute the solution. Massaging the extremities and using intermittent drainage also facilitates fluid distribution. High pressure and pulsation promote flow to the peripheral tissues, fingers, toes, ears, nose, and lips. Bluish discoloration in the fingertips can be manually cleared by squeezing the nail beds and forcing the discoloration to be removed through blood drainage. Dye can be added to trace the distribution of solution in the tissues. Abnormal pH values may prevent embalmed tissues from adequately firming. A moderate to strong solution strength accompanied by a co-injection fluid and dye should meet the preservative demands despite the lack of tissue firming. Using restricted cervical injection, a large volume of solution can be injected without concern of swelling the features of the face. Large volumes also promote better fluid diffusion. Cavity embalming must be thorough to arrest mycotic infections that may be present in the lungs. Abscesses, necrosis, and gangrene of the pancreas and the liver are treated by a sufficient amount of cavity fluid. Cavity fluid is injected into each major body cavity, thoracic, abdominal, and pelvic, for a recommended total volume of 32 to 48 ounces. Based on embalming analysis, additional volumes may be necessary. Decubitus ulcers are topically disinfected. Marginal tissues are injected hypodermically with cavity fluid or a phenol cautery solution. Surface compresses are applied to the necrotic surface tissues. When the compress is to remain in place, an adult incontinence brief is helpful. Plastic pants are recommended to protect clothing and contain odors. Gangrene may be present in the distal tissues such as fingers and the toes. These areas will not receive arterial solution when the body is arterially injected. Cavity fluid or phenol cauterant can be hypodermically injected into these areas. The surface of the feet affected by gangrene can be coated with autopsy gel or cavity fluid compresses. Plastic stockings protect clothing and contain odors. Extravascular resistance. External pressure upon an artery or a vein causes the lumen to narrow or collapse, creating resistance within the vessel. This is called extravascular resistance. Extravascular resistance restricts flow within the vessel. So examples of some extravascular resistance, we have rigor mortis. Relieve as much rigor as possible prior to arterial injection. Ascites. Drain the fluid in the abdomen prior to or during arterial injection. Gas in the cavities. Release gases in the abdomen prior to or during arterial injection. Bandages. Remove tight bandages prior to injection. Contact pressure. Massage the affected areas. Tumors. Excise when necessary, and understand if you are going to excise a tumor, permission is required to do that from the legally authorized person. Swollen lymph nodes. Treat with sectional injection. Hydrothorax. Drainage of the pleural cavities may be impractical prior to embalming. Now, the reason for this, well, let's elaborate on this for just a second. The reason for this is if you are going to go in and try to drain the pleural cavities, the lungs, there is a good chance that you could nick something with your trocar that could cause you to rupture the aorta or the descending aorta at that point, thus turning it into a multi-point injection. So it's not that you can't go in and try to do that, but if you do, insert the trocar at the normal point of entry, keep it towards the anterior portion of the body, and then gently push it into that thorax so that once you do penetrate into the area through the diaphragm, You don't have to really poke hard or play around trying to find the sweet spot to get that liquid out. Visceral weight. Utilize injection and drainage points above and below the heart. In general, when you're dealing with extravascular resistance, multi-point injection is recommended. Higher embalming pressures improve distribution. Moderate to strong, well-coordinated arterial solutions are effective when distribution is limited. And tissue massage also promotes optimal fluid distribution and blood drainage. That concludes this lecture, and folks, we'll see you next video.